So today we will talk about myeloid-derived suppressor cells. The title, as you see, targeting myeloid-derived suppressor cells, short MDSCs, in melanoma microenvironment. So the microenvironment, tumor microenvironment, consists, of course, not only of tumor cells, but also a lot of host cells, and among them, very important immune cells. And it's happened like this. Now we're understanding more that there is like a kind of meeting or interaction between so-called bad and good guys. So the cells, bad cells, immune cells, which can support tumor progression, and good cells, which can support tumor rejection. So for tumor rejections, what are important, it's CD8 T cells, CD4 T lymphocytes, Th1, especially natural killer cells, natural killer T cells. It's like a kind of hybrid between T cells and NK cells, M1 macrophages, and also probably B cells. It's still not clear completely if B cells are bad or good guys. For tumor progressions or important regulatory T cells, CD4 T cells, CD4 Th2 T cells, NK T cells type 2, and then myeloid-derived suppressor cells, about which we will talk today, M2 macrophages, and regulatory dendritic cells. So as I told, we will focus on one, but very, very important participant, myeloid-derived suppressor cells. So these cells are actually not existing in the normal bodies, not in healthy organisms. So they can be generated only in the process of chronic inflammation or tumor development. So normally, myeloid cells are generated from hematopoietic stem cells and then going through different precursors to monocytes, macrophages, dendritic cells, and the neutrophils. But as I told, during chronic inflammation, and tumor development, there is a constant production, long-lasting production of inflammatory factors. So they are very important for acute inflammation. They can stimulate T cell immune response, but during chronic inflammation, when they are produced constantly, so they work counterproductive, and they partially block this differentiation, normal differentiation, which actually is resulted in the accumulation of not fully mature precursors with the morphology of monocytes and neutrophils. And what is important, they have a very, very strong immunosuppressive function. So these two populations are known monocytic MDSCs, MMDSC, and polymorphonuclear MDSC. In mouse, they have MDSC, this common marker, CD11BGR1, and PMN MDSC can be distinguished from MMDSC by the expression of L/6C and L/6G, different expression. In human, the situation is more complicated because we don't have GR1 marker, so that's why we have to rely on CD15 and LOX1 for PMN MDSCs and CD14 for monocytic MDSC. So there is another, the third population found in human, so-called early MDSC without any immunosuppressive activity. Interestingly, there is so far no counterparts in mouse. Now, MDSC can be generated, like always, the process of generation of myeloid cells happened in the bone marrow, and they have to be recruited to the tumor site through the vessels. And here, the role of chemokines is extremely, extremely important. In general, we can consider that the process of generation and activation of MDSC could be divided on two steps. So the first step is the generation and migration of MDSC. And here you see this important factors like VEGF, GM-CSF, IL-6 are playing a crucial role. CCL3, so this is chemokines 4 and 5, and transcription factor STAT3 is dominated. So that's why it's a very important targeting molecule could be. The second step, which happened actually mostly in the tumor lesions, and which is extremely important, and this is just because MDC making like a shield, like a barrier for T cells to act. So their activation happened exactly there, and they include factors like interferon gamma, IL-1 beta, TNF-alpha, which is produced by activated T cells. So you see, this is a very peculiar process. Also, toll-like receptor ligands. And if we look on the MDC signaling pathway, so they are actually not different from the normal myeloid cells, because we have the same receptors, and more important also the expression of toll-like receptors. And we will talk about this a little bit later, more precisely, because toll-like receptor ligands, also present in the pathogens, but also on the tumor cells, can stimulate immunosuppressive activity of myeloid-derived suppressor cells through the activation of NF-kappa B. And the problem of these cells is that they are immunosuppressive activity is multifaceted, really. They can make a lot of immunosuppressive molecule and a lot of mechanisms. So here I just try to list only probably a couple of them. One is, for example, induction in other immunosuppressive cells like regulatory T cells or M2 macrophages. Impaired lymphocyte homing, they can also block the homing of T cells into the lymph nodes. They produce free radicals, for example, reactive oxygen species or nitric oxide, which can lead to apoptosis of T cells. It's like more or less we compare with the atomic bomb explosion. So if T cells are very close to MDCs producing nitric oxide, so they can die from apoptosis. But if they are just have some distance, so then they are survived, but they have a reduced function, like reduced zeta chain expression of T cell receptor and inhibition of their proliferation. Moreover, nitric oxide can also make an iteration of T cell receptors, which is leading actually to the inability for T cells to recognize the antigen. Moreover, MDCs can also deplete microenvironment from a very important amino acid, essential amino acid like L-arginine or tryptophan, and T cells cannot produce by themselves. So they're very much dependent on import, and you see it's happened like with some countries which are depending on the import. They can, of course, suffer in case this production will be, or supply will be blocked. And MDC are able to, through nitric oxide synthase or arginase activity, can block the production of arginine. MDC also can produce, through this ecto enzyme CD73 and CD39, produce adenosine from ATP. And adenosine is a very important immunosuppressive factor, leading to the block of T cell proliferation through increased production of cyclic AMP. And the next, or last, which I mentioned here, would like to mention here, is the expression of PD-L1. Of course, you have heard about this axis PD-L1 and PD-1. Expressed on activated T cells, PD-L1 expressed on MDC, and they can block T cell activity, inducing T cell energy. And interesting that this blocking can be removed, and then T cell can be again awaked. And this is the one mechanism how anti-PD-1, anti-blocking antibodies are working. So just to conclude this part, so we have a chronic inflammatory condition, so which is typical also for tumor development, which is characterized by the constant production or long-term production of inflammatory cytokines and chemokines, which leads to the accumulation migration MDSC to the tumor site, where tumor can also support MDSC activities through the production of prostaglandin E2 or VEGF, but also our friends, effector T cells and NK cells, by production of TNF-alpha and interferon gamma, can severely increase the immunosuppressive activity of MDSC. But what was found quite recently is that there is another mechanism of the generation of MDSC, not dealing with the partial block of myeloid cell differentiation, in particular the production of extracellular vesicles by tumor cells, which can actually convert even normal, fully differentiated myeloid cells, for example, in mice in the bone marrow or in human monocytes, into immunosuppressive cells, which can be defined as myeloid-derived suppressor cells. So there are two possibilities existing, and it's difficult to judge in particular patient which mechanism is more important. So both probably are important. So a couple of words about extracellular vesicles. I don't know if you have heard already about these vesicles, but just to let you know that there are three classes. It's like microvesicles, exosomes, and apoptotic bodies. And the difference between microvesicles and exosomes, it's not so strong. Microvesicles shed directly from the plasma membrane here, but exosomes, they make more a complicated way to be produced, so they derive from endosomal system and release upon fusion with plasma membrane. What is important, that extracellular vesicle could contain all the proteins, microRNA, mRNA, typical for initial cells which are producing these vesicles. So what is known, that in principle all cells can produce these vesicles, also normal cells, but quickly proliferating cells, and of course tumor cells are belonging to these cells, so they can produce enormous amount of exosomes. So what we did in our experiments, so we actually isolate exosomes from tumor cells, melanoma cells, using serum-free supernatant and ultrafiltration, and then centrifugation. What is important is to show that you are really dealing with extracellular vesicles. You make this nanoparticle tracking analysis, which can show you the size of vesicles and also their concentration. Then you have to make an Western blot analysis to show the markers CD8, CD81, ALEX produced on extracellular vesicles, and no calreticulin, which is typical for the lysate of these red melanoma cells. What we found actually, that after incubation of immature myeloid cells from the bone marrow, CD11b, J1 double positive, so these tumor-derived EVs can induce the expression of PD-L1, which is, you remember, one of the important factors of immunosuppression. And this induction is really tumor specific, because if you use as a control EVs produced, or extracellular vesicle produced by normal cardiac fibroblasts, so there is no upregulation. This happened also not only in the amount of cells expressing PD-L1, but also the level of PD-L1 expression, and what is more importantly, that these myeloid cells are able really to inhibit T cell proliferation. So T cells are proliferating with the help of CD3, CD28 antibodies, and then you co-incubate the cells with myeloid cells treated with exosomes, and then you see the proliferation is significantly inhibited. Now, we wanted to know what is the mechanism of this PD-L1 upregulation. Is it working through toll-like receptor? And the answer is yes. Well, we used toll-like receptor knockout mice when we isolated extra myeloid cells from these mice and treated with tumor-derived exosomes. We found no practical upregulation of PD-L1. Toll-like receptor 2 and 7 had less important effect. Moreover, but it's not only PD-L1, but also, of course, the inhibition of T-cell proliferation was not possible in case myeloid cells were derived from toll-like receptor knockout mice. Okay, so toll-like receptor 4 is playing an important role, but what about the factor from on the side of exosomes? What is working there? And we found it's actually heat shock protein 86 or 90, so another name of this, and really extracellular vesicles strongly express this HSP86. If we make a downregulation with siRNA HSP86 expression in tumor cells and isolate exosomes from them, so then after treatment with myeloid cells, so they were not able to upregulate PD-L1. And these cells also were not able to inhibit T-cell proliferation. Now, the question is, of course, if it's only in vitro phenomenon or it's working also in vivo. Therefore, we use this HSP86 knockout red cells or knockdown red cells, red melanoma cells, and injected them in vivo, and wanted just to see the tumor growth. And really, we found that they are growing slower, significantly slower than the normal, so to say, red cells. We wanted to know if it's a problem of tumor cells, and we used this tumor cell proliferation assay in vitro. The answer was no. The cells are proliferating very good, so it means that probably something going with the host cells. And really, we found that tumors from these melanoma red cells, which were no expression of HSP86, there is a less accumulation of myeloid-derived suppressor cells. And moreover, these accumulated myeloid-derived suppressor cells, so they express also less PD-L1. Now, coming to our experiments and for targeting of melanoma cells, so myeloid-derived suppressor cells, so we used the mouse model, which is spontaneously develop melanoma, so-called red transgenic model, characterized by the overexpression of receptor tyrosine kinase red in melanin-containing cells, which leads to the spontaneous melanoma development with this relatively quickly, with median 40 days, and which has this model also metastasis in lymph nodes, visible metastasis. So I just try to show you, this is the primary tumor and this is lymph node metastasis. But they have also metastasis in liver, lungs, brain, and bone marrow. Unfortunately, due to this new regulation in Europe, so we are not able now just to leave the mice just develop the tumor up to 2 centimeters. So now it's only 1.5. That's why previously we could see really in the bone marrow, at least half of the mice, or in the brain, they have a visible metastasis. Now we can see only microscopic metastasis because we are not able to wait longer. What about MDSC? So what we found that there is a constant accumulation of CD11 BGR1 double positive myeloid-derived suppressor cells, which are characterized by the production of immunosuppressive factors, so like nitric oxide or overexpression of arginase 1. So this is the second marker for to call these cells MDSCs, but the third, which is the most important, to show that they have immunosuppressive function. And you see here, we co-incubate, again, as you saw before, we stimulated T cells and then co-incubated them with MDSC. And we found that the proliferation of this after this co-culture is significantly reduced. Now, as I told, there are two subsets, polymorphonuclear MDSC, like neutrophil-like MDSC, and monocyte-like monocytic MDSC. We wanted to know how they are distributed and found that actually in metastatic lymph node, there is a prevalence of polymorphonuclear MDSCs also in the bone marrow, in spleen, and in the blood. The thing is that monocytic MDSC are living longer, whereas PMN MDSC are dying very quickly. So it's necessary then always to have some kind of refreshment of this population. But what is important that the accumulation of PMN MDSCs really happened correlates with the accumulation of the tumor mass, which is not the case for monocytic MDSC. When we looked on the immunosuppressive pattern, so we found that the expression, for example, of PD-L1 is more or less the same. The expression of ectoenzymes is higher in PMN MDSC than MMDSC, but at the end, when we looked on the immunosuppressive activity of both subpopulations, so the activity was more or less the same. There is no statistical difference. So it seemed that both populations are equally active in the immunosuppressive activity. Now, what about the expression of chemokine receptor? Because they are important for the migration of these cells into the tumor. And we found that there are two particular chemokine receptors which are differently expressed in both populations. So MMDC is population is characterized by the predominant expression of CCR2, whereas PMN MDSC are more characterized by CXCR2. What is important also that CXCR2 is not expressed or almost not expressed in other myeloid cells and lymphoid cells, like in regulatory T cells, NK cells, macrophages we tested, in red cells, CD8 T cells. This is very important because one can think about specific targeting through the interaction with this receptor. Now, what about the ligand? We know that there are two ligands for chemokines for CXCR2 receptor, it's CXCL1 and CXCL5, and we found that there is a very strong, almost 4 times gradient between the tumor and plasma. So it means it's like a pump from the circulation induce the accumulation of CXCR2 positive PMN MDSC, and you see here it's practically almost 100% of PMN MDSCs. Moreover, there is a really, in mice, the correlation between, statistically significant correlation between the amount of CXCL1 in the tumor and the percentage of PMN MDSC in the tumor accumulation. Now, what about, is it only a phenomenon of mice? No, it's also happened in human, because we found also that during the melanoma development, there is an accumulation of monocytic MDSC. You see the different stages, and there is an accumulation of cells expressing PD-L1. So it means that increased frequency and immunosuppressive pattern of circulating MDSC during melanoma progression. Moreover, the patient having low MDSC amount, they have better clinical outcome, characterized, for example, by the progression-free survival. So enrichment of circulating MDSC correlated with the worse clinical outcome. What about the response to immune checkpoint inhibitors, response to the dominant now immunotherapy in melanoma. So really we found that there is accumulation of MMDC in non-responders, and non-responders, they can produce also higher amount, this MMDC, high amount of nitric oxide, whereas PMNMDC can express higher level of PD-L1 in non-responders. So MDC can be used as a biomarker detecting the group of patients who may benefit from the therapy with immune checkpoint inhibitors, in particular ipilimumab, anti-CTLA-4 antibodies. But it's also the same data we found for anti-PD-1 antibodies. So the take-home message one is that increased frequency and immune suppressive pattern of circulating MDC is characterized or is important during melanoma progression. Then the next, enrichment of circulating MDC correlated with the worst clinical outcome, and MDC can be used as a biomarker for patients who can benefit from this therapy with checkpoint inhibitors. Now we're coming to the second part of our discussion. It's how can we target MDC? So as I told, there are a lot of possibilities for MDC to induce the activity, and therefore, unfortunately, we cannot find really this magic bullet which can be like touched and inhibit, and then all MDC can be silenced. Unfortunately, we have to use different approach, and they can be divided into these three groups. For example, we try to deplete MDC or inhibit the immunosuppressive activity or block their migration into the tumor, because this is the main battle of this war between tumor cells and host cells. At the moment, there are 36 ongoing clinical trials in cancer patients, and 6 of them are dealing with the combination of MDC targeting and immune checkpoint inhibitors. So now we start with the first example, how we can deplete MDC. When we used an ultra-low dose of chemotherapeutic paclitaxel, so we injected in mice 1 milligram per kilogram, and we found actually that there is a strong inhibition or strong increase of mouse survival, which is actually characterized by the strong inhibition or the decrease in the amount of MDC in tumor and decrease in the production of the tumor inflammatory inflammatory factors in the tumor. Most importantly, that MDC isolated from the tumors of paclitaxel-treated mice, they are not so immunosuppressive as MDC from untreated mice. So then also immunosuppressive function was downregulated. What is important that of course, T cells feel themselves better because the frequency CD8 T cells is increased in the tumor. The expression of zeta chain in CD8 T cells is also upregulated, and this zeta chain is important for the signaling from the surface of T cells to the nucleus. And what is important that if you block anti-CD8 with a specific antibodies, so you can completely remove the immunotherapeutic effect. So it means that CD8 are playing a critical role in the tumor rejection. Now, we tried to do also some small clinical trials in our University Medical Hospital in Mannheim, and what we found there that out of 9 patients, so 3 showed the partial response or stable disease. And what's characteristic is also that we saw in the responders decrease of monocytic MDC, both in the circulation and also in the tumor metastasis. This MDC in responders, they express less PD-L1 and produce less nitric oxide. Now, the T cells, so it's again the same what we saw in mice. There is an responders accumulation of T cells in the tumor and increase the expression of TCR-zeta chain. And here also in responders accumulation of activated CD8, CD25 double positive T cells. Now, the next example, how we can inhibit immunosuppressive activity. So for this, we use sildenafil or Viagra, which inhibit phosphodiesterase 5. Sildenafil can block the activity of phosphodiesterase 5, which degrades cyclic GMP. So cyclic GMP is accumulated, and cyclic GMP is important for the production of activation of inducible nitric oxide synthase, which can produce nitric oxide, activate quinolate cyclase, which can go to cyclic GMP. But in case we have enough cyclic GMP, so it's not necessary just to activate inducible nitric oxide synthase, because there is no necessary to produce cyclic GMP. What we found, the mice, they receive sildenafil with the drinking water, and we found again increase in the survival. We found the strong decrease in the production of nitric oxide and arginase 1 expression, and again severe also inhibition or less severe inhibition of T cell activity, T cell proliferation of myeloid-derived suppressor cells from sildenafil treated mice. Again, we tried to do this small trial in Heidelberg in National Cancer Center using advanced melanoma patients, so who received all possible therapies, ipilimumab and chemotherapy. And we found actually again three patients, they show the response, which characterized by stable disease. It means that the tumor was not growing at all or metastasis. And one of the good examples, so you see the growth of the tumor after ipilimumab injection. So they were completely resistant to ipilimumab, but then after treatment with only 5 milligrams of tadalafil, there is a strong decrease in the tumor. Again, in stable disease patients, so in responders, so they were characterized by the decrease in monocytic MDSC, whereas progressive disease patients, so they show no difference or even increase in MDSC, and the same was found actually in the monocytic MDSC infiltrated tumor, again from the T cells. So we saw the accumulation of CD8 T cells in the tumor in patients with stable disease, increased TCR-zeta chain expression, both in tumor infiltrating CD8 and CD4 T cells. The last example, so I want to show you how we can block the MDSC migration. So as you remember, I told you that PMN and MDSC are characterized by a strong expression of CXCR2 receptor, chemokine receptor. So we used an inhibitor, again, treated the mice, and we found that this CXCR2 inhibitor can prolong mouse survival. We make also tumor weight at particular time points, 21 days, 28 days. Of course, these are different mice, and we found that tumor, it's not only prolonged survival, but really anti-tumor effect. And what is interesting that we expected to have, as with in other situations, the accumulation of CD8 T cells, but it was not the case here. We found here an accumulation of NK cells. It was like a surprise. Moreover, the amount of NK cells infiltrating tumor inversely correlate with the frequency of PMN and MDSC infiltrating tumor. We made some experiments to show how NK cells can be, what is the mechanism of the involvement and why PMN and MDSC are so important for NK cells. And we found after co-incubation of NK cells and isolated subpopulation of MDSC, like monocytic MDSC and or polymorphonuclear MDSC with NK cells, we found that after the treatment with PMN MDSC co-culture, NK cells can produce much less interferon gamma, which is the characteristic of their function. So PMN MDSC are really important for the downregulation of NK activity. So now we're trying to figure out, we still don't know exactly why PMN MDSC are working and not MMDC, but we are trying to figure out what is the difference with regards to NK cells, why PMN MDC are so important. As I told you now, it's very difficult to analyze distant metastasis in this red transgenic mouse model. That's why we used another approach, which was developed in German cancer, in our cancer research center in Heidelberg by Professor Augustin, dealing with the transplantation of the tumor fragments and then resection of the primary tumor. And then these mice can develop distant metastasis in lung, liver, but also in the lymph node. But we found that in distant metastasis, there is a real accumulation of PMN MDSCs in comparison, for example, to MMDCs. And PMN MDC can strongly, really in distant metastasis express CXCR2, much stronger than in the primary tumors. And when we just treated the mice on this stage, when primary tumor was already removed and metastasis was developed, and we looked at the survival of these mice, and you see it takes a long time because the metastasis need time to be developed, but we found a very strong increase of the survival of mice treated with CXCR2 inhibitors. Again, we wanted to look on the mechanism, and we found really that there is a decrease of PMN MDC, and this we looked in pre-metastatic lymph nodes. So it's still before metastasis clinically visible were developed, and again, accumulation of NK cells. So it seems that the accumulation of NK cells plays a principal role in the blocking or reducing the development of metastasis. And again, we found that in pre-metastatic lymph node, there is a statistically significant correlation between the accumulation of PMN MDC and inverse correlation and the amount of NK cells. So less NK cells we have here, then more PMN MDC are accumulated in the tumor. Now we are coming to the end of the lecture, so we want now to discuss what could be the future immunotherapeutic strategy, what is important, what we can do. Of course, the important, especially talking about melanoma or other tumors with a high immunosuppressive capacity, like, for example, lung cancer or head and neck cancer, colon cancer, and so on. We should think about the blocking of immunosuppressive activity of myeloid-derived suppressor cells. And this targeting of MDSC should be done in the combination. Now it's obvious with negative checkpoint inhibitors or immune checkpoint inhibitors, like, for example, anti-PD-1 antibodies like nivolumab or so on. We can combine this also with adoptive transfer of T cells. So the first approach is already approved and used in Europe and the United States. The second, adoptive T cell transfer, unfortunately, is still on the level of clinical trials and still not improved. So probably it's a question of the future. The first one can use immediately. And in case we're dealing with, for example, not so immunogenic tumors, so it makes sense to use vaccination to increase immune response, and then try to block the activity of myeloid-derived suppressor cells. So I want just to illustrate this on this slide. So if we have two types of tumor, tumors characterized by immunogenic tumor microenvironment like melanoma or lung cancer, and non-immunogenic tumor. So then in immunogenic tumor, we can make the combination of immune checkpoint inhibitors and different types of MDSC targeting. By the way, it's also very interesting that not all patients, so they have the same pattern of immunosuppressive activity of MDSC. So it means not everybody, for example, can use MDSC, can use all these 6 mechanisms which I showed. So they can probably, one can use one mechanism, another mechanism. So that's why it's strictly important to make profiling of MDSC from the patient, just to know which exactly mechanism is working. With non-immunogenic tumor, we should induce first immunogenic tumor microenvironment, for example, through the vaccination with for example, peptide, which are uniquely expressed in this particular tumor. So this so-called specific tumor antigens, which are not expressed, for example, in host cells, and then can use the combination between immune checkpoint inhibitors and MDSC targeting. Now, the last take-home message, the second one, will be following. So first, MDSC, in contrast to other immunosuppressive cells, for example, like regulatory T cells, they are not present in the healthy individuals. Important that, for example, the regulatory T cells are present in everybody and all people, also healthy people, and the absence of regulatory T cells, which can lead to the development of autoimmune disease. So they're extremely important for physiological also homeostasis, whereas MDSC, it's typically pathological cells. They are generated and activated under chronic inflammation and tumor progression. They can strongly suppress anti-tumor activity of T cells and NK cells via multiple mechanisms. MDSC have high plasticity and can convert to other myeloid regulatory cells like M2 macrophages or regulatory disease. And the general conclusion is that MDSC are playing a central role in tumor-induced immunosuppression, at least for melanoma, is quite obvious. So, and this is the end of my talk. Thank you very much for your attention, and we have time to discuss the points which we have heard this afternoon, and I'm looking forward for your questions. Thank you.
Thank you very much, Professor, for so interesting and very complex lecture. Dear participants, do you have any question to Professor? Okay, so maybe I'm starting. So, Professor, in your lecture, you describe some approaches that you use for experimental therapy. What of these approaches, in your opinion, is most perspective for further usage in wide clinical practice?
Well, I think that what is interesting and can be relatively easy used and not so let's say expensive is for example, the blocking of the migration of myeloid-derived suppressor cells. We have also some other inhibitors of the migration. So I showed you only one example, but there is another one inhibitor of CCR5. For example, blockade of CCR5, which is actually used also for the treatment of HIV patients. And this can be, but this is only approved for HIV, this inhibitor. But we are thinking about using this also in the treatment of cancer patient. Yeah. Then, well, I would say that, for example, this long-lasting inhibitor of phosphodiesterase 5, like tadalafil, can be also important. The important thing is also just to look exactly, as I told you, to make profiling of monocyte in general monocytic polymorphonuclear MDSC from particular melanoma patient or other tumor patient, and then just try to use different agents. So at the moment we have the problem, of course, that this should be approved for the immunotherapy, and we have no possibility actually to use these MDSC blockers alone. But I think it would be very nice to make the combination, and it would be easy or much easier to make the clinical trials. But we need to make clinical trials. So there are some clinical trials, so as I told you, ongoing. But I think the end aim to supply doctors with several inhibitors, so that they can try different inhibitors, so block MDSCs, and to start this relatively early, not to wait until the patient will show non-responsiveness to immune checkpoint inhibitors.
Okay, thank you very much. We have a question from Nick Stenikov. Nick, please ask.
Good day.
Yeah.
I have an idea that your talk could be relate to public health, but I'll tell scenario. But if it is totally fictional, tell me please. So, for example, we have a person who wants to donate blood. And he or she passes tests, common tests for infections, which pass such people, for example, for hepatitis B, but he or she has hidden tumor, still undiagnosed, and he or she donates blood, and some recipient it receives. So as I see from your report, this tumor could produce microvesicles, which also recipient receives, and could so there are two questions. Could myeloid cells, could the myeloid suppressor cells develop in recipient of such blood, and could they be, for example, predisposition for developing of tumors in this person?
So the point is that myeloid cells, in general, so they live not so long, and so they're dying very quickly. And the recipient, if even, well, theoretically, this possibility existing, of course, from the blood, so the cells are not so immunosuppressive as, for example, isolated from the tumor, right? But what is important, the recipient, if she or he doesn't have any chronic inflammation or tumor development, so they have no condition to develop new, so the MDSC. So these MDSCs will be just going and then die. It's one point. Another point is that MDSC by themselves, they cannot induce tumor development. They are working actually more or less on the relatively late stage, although they appear already in the early stage, but accumulating in the relatively late stage when T cells are activating and trying to do something with the tumor. And but this is like a counter mechanism to reduce T cell activity, which is actually should be also in the normal individuals, but in the tumor patients, so unfortunately. So it leads to the downregulation of T cells before T cells can reject tumors. So it means that there is no, in the recipient, there is no driving forces for support the development of MDSC. So therefore, there is no, from my point of view, no danger.
So donors shouldn't pass oncoscreening, yes?
From the point of recipient, no. But of course, they should pass just for themselves.
Mm-hmm. Thank you a lot.
Yeah, you're welcome.
Okay,
we have some questions.
Chat,
do you want to?
I will, yes, I will read it now. So the first question from Mikhail Ivansov: what are you planning to research in the most nearest future, and what methods will you apply to succeed there?
Well, we are now trying, I told you about exosomes, so we are now trying to figure out the mechanism, how heat shock proteins are really working on the upregulation of activity of myeloid-derived suppressor cells, or the conversion of normal monocytes into myeloid-derived suppressor cells, what is important for them. And we found that really, for example, the tryptophan or IDO, this is enzyme model downregulating or degrading tryptophan is playing an important role. So this is what we are focusing on. We worked also in trying now to publish a paper not dealing with tumor, but with this COVID story. Well, we studied immune monitor just 25 people receiving vaccination against COVID, and just looking on the expression of T cells and K cells and myeloid cells, and we found there is no, after vaccination, which is important news, also no activation of myeloid-derived or generation of myeloid-derived suppressor cells. And the method which we are using is actually the inhibition of this T cell proliferation and ELISA production of different cytokines, so Luminex and cell culture, and also, of course, the microarray analysis, so different proteomics analysis, just to see what is different, or what is the difference between, for example, let's put it this way, normal monocytes and monocytes converted into immunosuppressive myeloid cells, which molecules are differently expressed and which signaling pathways are involved.
Thank you. We have one more question from Dmitry Alexandrovich. Are there some risk of side effects during and after this procedure, and how they are severe?
But which procedure do you mean? It's not clear. Which procedure?
I mean immunotherapy.
In general, immunotherapy?
Yes.
Well, if we're talking about immunotherapy with immune checkpoint inhibitors, of course, they have like autoimmune reactions, so they could have some this immune-related side effects, and they can be really severe, even up to, for example, the damage of gastrointestinal tract with some inflammation, like colitis, for example, but it's relatively rare effect. More important that they have some, well, like one of the most, let's say, non-dangerous effect. It's the development of vitiligo. So it means that like a white spots on the skin. Yeah. So, and yeah, then of course, if this autoimmune reaction are developed, so then the clinicians, so they should stop the treatment with immune checkpoint inhibitors, and then they can use some corticosteroid treatments, for example, to block the development of autoimmune reaction.
Thank you. And one more question from Daria Zatinatska. How does the tumor microenvironment influence the growth, invasion, and metastasis of tumor cells?
Well, this is just what we are studying and what we told about. Of course, tumor microenvironment, there is a constant battle between bad and good guys. And let's put in very general way, if bad guys are winning, and then of course tumor starts to grow and metastasis also accelerated, so the metastatic process. And if other way around, if T cells are able to block, to reject tumor cells, so then of course, then it goes in different directions. So the tumor environment, some people call this even tumor immunoenvironment, yeah, because it's actually microenvironment is mostly composed on immune cells, different sorts of immune cells. So of course it's playing an important role, and it depends how the outcome of this battle, in which direction it will go.
Okay, thank you very much. Maybe our participants have any additional questions? So, okay, if not, I want to say thank you to Professor Umansky for such interesting lecture. Indeed, we know that based on a very severe effects of traditional chemotherapy, we should find new approaches that help us to fight cancers and another tumor diseases. And I think that immunotherapy compared with gene therapy or with the gene therapy could give us a good weapon to fight such severe and deadly diseases. Yeah. Thank you very much, Professor, that you participate our summer school, and we looking forward to see you in Odessa next year and listen more interesting lectures from your side.
Yeah, so thank you very much, and I want to tell to everybody, so in these very dangerous and unfavorable times, stay strong, and we hope for the best. And I really hope very much that next year we can meet really in summer in Odessa, so to say, live, and that you can also participate in different international meetings. There is a very huge support of Ukrainian scientists, in particular in Germany, where you can apply for some stipends for visiting some conferences. Yeah, of course, during the war, it's difficult to leave the country, and for men, it's even not possible. But we hope for the best, and stay strong, and all the best. And I hope that everybody will be healthy and that everything will be okay.
Thank you, Professor, for such warm words. So thank you very much for your lecture, and see you next year. We hope in offline format, but if not, we're looking forward to see you on our online summer school. Thank you very much.
Welcome.